Hello, everyone. Welcome back to the Queer See Me podcast. Thank you so much for joining me today. Patricio, I'm super excited to have you. We met in Alaska, which is weird because neither one of us live there.
Yes, definitely. I'm so excited to be here. But yeah, it was a weird chance meeting, but a very good one.
Yes. Yes. So can you tell our audience who you are, your pronouns, how you identify, and then we'll go what you do next.
Sure. So my name is Patricio Batani. I'm pronoun indifferent, so I don't really use any pronouns specifically, just whatever. And I identify as queer in both gender and sexuality. So a lot of people refer to it as trans, non-binary, if we want to get very specific, but I don't know. I'm just kind of hanging out on the outskirts, I think.
I really enjoy visual representations of gender, and so I feel like hanging out on the outskirts gives a very visual impact. One of my guests in collegial people I worked with one time described her gender, and I don't actually remember their pronouns. But described the gender as a field with different boxes in it, and then there's a cat that wanders into the boxes and out of the boxes, and so there's a whole fourth dimension of movement. It was really, but it was so visual and fun. So thank you for sharing that. Yes, and you work directly within the field of gender affirming care. So tell our audience what you do.
Sure. So I actually am an electrologist. So technically, I have a master's degree in public health, and so I spent the last 25 years doing HIV work. And while I was at a previous employer, we had started a trans navigation program, and the one thing that came out of it was the fact that we had no electrologists here in Hawaii. And right now there are 4, so for the entire state. And somebody once told me that Hawaii has the most trans people in the US. So, but I don't know how true that really is, but my book is really full. So, but yeah, so I started an organization. It's called Hi Sis for Hawaii Electrolysis. And I went to electrology school because I jokingly said one day in a meeting that if we can't find anyone else to do it, I'll just do it myself. Well, that turned into actually doing it myself.
Yeah.
So I've been doing that. We're going on 3 years this year. And so I've been doing that. And then we started a school so that we could actually have more people to actually do this. Because I went from 30 clients to 150 in less than a year. So yeah, it's a little insane. About 90% of the people we do electrology for is gender affirming care. So, but in the kind of side of that now, we're also doing a whole bunch of other things that are gender affirming, kind of, I don't want to call it cosmetic care, but most people would refer to it as cosmetic. But
I just call it aesthetic. I don't know why that word has less negative connotations to me, and feels to bridge the gap between I don't know if it's a gap, but I feel gender affirming aesthetics, right?
Yeah.
And it's interesting. It's such a complex and nuanced thing, right? Because gender dysphoria is real and exists. It also exists within the culture of white supremacy and the patriarchy, which has put these unrealistic ideal standards of beauty on all of our bodies. And so it can be very nuanced and complex for sure to pick those things apart, and sometimes they can't be separated. But for whatever reason, I feel cosmetic has these kind of negative connotations of rich white ladies getting their boob jobs.
Yeah, no, definitely. Yeah, I agree. There is some real negative connotation, especially within Hawaii. It is a colonized space and a very recently colonized space. And so that's something that we do take into consideration too that, beauty is kind of white supremacy ideology, weight and stuff like that. And so one of the biggest things that I do try to do in practice is, obviously consensual touching. And then also in addition to that, kind of hearing people out about their concerns of hair and explaining to them the purpose of hair, and just being like, we have hair for a reason. And most of that reason is to keep us warm and or keep germs out of us. And so I think sometimes reducing it to that kind of medical, like functionality helps them to understand that, we're not doing this because of that beauty standard. We're doing this because, one, you have dysphoria about it. And two, like, I'm not here to make you pretty. I'm just here to help you survive at this point.
Yeah, right. And like, pretty comes in all shapes and sizes, right? I think in like queer and trans spaces, at least in the ones I move in, that like is such a celebrated reality, and I love that. And as someone who like plays very hard into those ideal standards of beauty in my presentation, like I like also am very happy to celebrate people who are like, yeah, I just want it to look like this. Great. It's your fucking body. Let's do that. So, but I love when like, right, we can have that interaction with our clients, with our patients, to like really acknowledge all of those things that are moving in this space when we're doing these things. And yeah, so it's like, for whatever reason, so much of cosmetic surgery is gender affirming for cis people, right? I feel like maybe the difference is like potentially there has been less intentional examination of the like standards being put on our bodies versus the things that we want internally for our bodies. And so I feel like that aesthetics term like separates it a little bit for me and just says like, yeah, these are gender affirming aesthetic procedures. Right. And so, yeah, but let's dive a little deeper for our listeners who are used to me getting on tangents about vocabulary, about hair removal in general. And I know your specialty is with an electrolysis machine or electrology. You always add, you say it differently than I'm used to hearing it. So can you first explain the pronunciation to me?
There's no wrong way to say it. So there's electrolysis, which is the like act of, and then you have like electrology, which is just kind of the concept of, I think that's kind of the best way to describe it. You kind of get funky because both of those terms also refer to like a chemical reaction that happens for like plating, like nickel plating too. So
I forgot. Yes. Yeah. God. Yes.
I mean, it's the same concept. It's the same chemical concept. It's just, two different, very different things. So
different applications. Okay. Yeah. And so, and I don't know how much information you have around laser hair removal too, because I would love to like kind of, if you could give an overview of each, and then maybe highlight the differences for our listeners, because most of our listeners are like referring providers, right? So this is like really important for them to understand when their patients are trying to understand.
Right. So what the best part is, like, and I'm glad that they're referring providers, because a lot of times it gets interchanged, and it's frustrating. So electrology, electrolysis, whatever you want to call it, is permanent hair removal. It's the only form of permanent hair removal that the FDA has cleared. And it's been around for over 150 years. I mean, it was started in the 1800s. It started out as removing eyelashes, ingrown eyelashes. That's how it started.
Ingrown.
Yeah, and so you can't, most states won't allow you to do that now, but you can do everything else. And so one of the biggest things is electrology is inserting a small probe, and the probe is the size of a hair follicle, whatever the size of the client's hair follicle is. And then we insert that and we release a specifically timed amount of energy. That energy either causes a chemical reaction, which is galvanic. It produces lye and destroys the cells, or it's thermolysis, which is radio frequency, which heats up. And so those are the two like main ways. And then there's one called the blend, which is both. And so you know, the electrologist, each electrologist does whatever one they do, and some of the people only do one, some people, you know, we do all three. It just depends on what type of hair someone has and stuff like that. So that's basically electrolysis. It's for everyone. There's no limitations on skin color, skin type, skin, you know, anything like that. The one thing I would do is if you're referring and the patient has moles or has any type of like skin abnormalities, to make sure that when you make that referral, you're also putting in there that you're okay with the electrologist doing care on those areas as well. So like I have a mole on my face, I have to have a physician sign off on that. And so that would just be helpful to know, you know, like especially if we're doing kind of areas where donor tissue is involved. So like kind of the vaginoplasty donor tissue. A lot of people don't realize that they have moles down there. So having a physician inspect that area first and say, okay, well, here's, you know, moles and stuff like that. And so that's a big thing. Laser hair.
I'm going to interrupt you. Sorry. I don't want us to lose our total train of thought, but would you, and part of it might depend on like the surgeon's desires too, but I'm wondering, like, would you typically recommend like removal before, like if it's particularly if it's going to be used for donor tissue? So like, you know, like you wouldn't necessarily want the mole like on the donor site. Would you recommend removal before hair removal of the mole, or would you do mole removal after hair removal?
I mean, that's up to the surgeon. I mean, if it's I would assume they would remove it before. I mean, that would be ideal, you know, so, but yeah, it's about checking that mole and making sure that it's one, not, you know, cancerous or potentially cancerous. And that, you know, we're just kind of, just because we as electrologists cannot make that decision to treat that, you know, it's better to have someone say, yes, I've seen this. It's fine with me. Okay. So yeah. But usually if I see something, I will tell the client like, oh, hey, you have a mole down here in this area. You need to speak to your primary care. Most primary care people are just making the referral and they're not looking. So, you know, they're expecting surgeons to look, and most people are coming to electrologists before they even have a surgeon.
Before they've seen a surgeon, yeah.
You know, so that's kind of a big thing.
Okay.
With laser is, there's two types of, well, there's multiple types of laser. There's different types of actual laser. So there's Alexandrite, there is YAG, and all of those things. Yeah. So those kind of like lasers, I call them the pew pew lasers because the applicator looks like a gun. They're the ones that kind of like fry the hair. And so what that's doing is it's actually looking for the melanin in the hair to destroy that. So that's why they're not effective on white, blonde, or red hair. They just can't do anything about it. And so those are relatively effective in terms of like if you have the proper skin tone versus hair color. So, you know, if you're white and you have dark hair, that's the ideal. For some, you know, lasers, you cannot have a darker skin tone. You cannot be on that kind of later end on the Fitzpatrick scale just because it could cause burning. There's another type of laser called IPL, or intense pulse light. And so that's just kind of the same thing, but it's just a really intense light rather than kind of a focused laser, if that makes sense. Yeah. So the IPL is now, one of the big things IPL has done is it's kind of paired up with radio frequency to create heat. And so they have now something called E-light hair removal. And that actually is painless. It's actually really great. I use it for some of my clients and it has done wonders. And so, you know, having a combination of those two things, the one thing about, let me back up for a second. The one thing about laser hair reduction is that it is just reduction. It's not going to remove everything. And there is a possibility that the hair may come back. And so that's the whole thing, which is why electrology should be the recommended form for donor tissue. So anything, especially with vaginoplasty, if we're going to do inversion, you really need to do electrology on it. Like that's just kind of the end game there. Because we do have folks, you know, here in Hawaii that I've seen who have intravaginal hair that have said, "Oh, I had laser though," and I'm like, "Well, there's nothing we can do about it once it's inside, unfortunately."
Yeah.
But
Yeah,
so
I'm gonna circle back just because you've said so many like valuable things, and I want to make sure the listeners hear them. When most lasers, like the most common lasers in practice in like aesthetic practices, and like more dermatologists sometimes have more options because they tend to have like more advanced machinery, but most common, like you can get a Groupon for it. Lasers don't treat blonde, red, white, or gray hair, right? And also don't treat people with darker skin. And
mostly,
so, yeah. And so that's like the most common ones. And then there are some practices that do house like energy devices to like classify. Let's just like throw all of them in there. That can serve people with darker skin and that can treat other hair colors, but those are a little bit harder to find. And I also often find that they don't tend to do like pricing packages in this like as competitively as like the lasers that are less applicable to like less body types.
Right.
Just to like give general information about like shopping for hair removal for people. And then I say kind of similar concept to how you present laser hair removal. I always call it semi-permanent. You say reduction, you say hair reduction, and you say it has a chance of coming back, and I say it's semi-permanent, meaning you will probably have to touch it up every 6 to 12 months.
Definitely.
Yeah, completely agree. And so if the tissue we're doing hair removal on is going to end up like more internally having a more permanent solution, because retained hair can cause significant dysphoria and distress for people. It can also cause some actual like physical presentation symptoms. So like irritation, discharge, malodorous discharge. And so definitely striving to have like complete hair free of that donor site, and electrolysis is going to be a more successful treatment for that.
Yeah, and so in going kind of back to the hair color, E-light is the only one that can effectively treat blonde and white hair. Red hair just tends to not be treatable with a laser just because of the way it works. But E-light can be effective, especially if it's like strawberry blonde, like if it's a little bit more blonde than it is red. So that's the only one that I know of personally that can actually do those hair types. And it is safe for every skin tone, E-light is. So, you know, and the way we do both electrology and laser here is we offer it. So in Hawaii, they're supposed to cover it by insurance standards. And of course, insurance never does. It requires this like huge amount of paperwork just to even get it covered. And then they don't pay us because we're not medical providers. And so that's something that we're dealing with here. So what we do often is for those folks who have the insurance that won't cover it, we offer those services at a dramatically reduced rate. Our whole organization is volunteer based. In the last 3 years, we've not gotten paid a dime. And so, you know, we do this because it is for the people. Like, you know, that sounds very political, for the people. But our goal is closing that gap on care, because it's just, even though it's the law, it's still there. And so, like, you know, either one of these like solutions in hair, especially if someone's seeing like specifically trans folks or specifically seeing like a lot more trans folks, it would be ideal for you if you're in private practice or even in practice in a larger kind of corporate setting to advocate for having an electrologist on your staff, have, you know, a laser in your practice, because, you know, when we look at huge conglomerates, kind of like Kaiser on the West Coast, you know, they're kind of the best like symbol or whatever example of an enclosed system. You know, I'm not saying that they're the best system or anything like that. I'm just saying they're it's just that their structure is ideal, you know, and because everything is inside of Kaiser. And so that's the one thing, you don't have to go to a million different places to get care. We do live on an island, but traffic in Hawaii, if you've ever driven in Hawaii, is incredibly horrible. And so it takes hours to get from the west side to our office. And there's nobody on the west side, and so there's a lot when it comes to these specifically hair removal services. I encourage people just to look into having someone even part-time. If you're at a federally qualified health center, do it. I'm sure there's a grant out there, and if you need help, just call us. We will definitely help you write the grant. But it's just those types of things. It's just an advocacy that we just, and there's a lot of states that are unlicensed.
I'm so sorry. Someone's knocking on my front door. I will be right back.
Okay, that's fine.
Go to the bathroom if you need to. Hi, Dog. You want to come upstairs? Sorry, it was like my hazelnut milk delivery. So random. Okay, yes. So definitely encouraging clinics and health systems and FQHCs to incorporate hair removal into the primary care setting would be a huge part of increasing access for trans and gender diverse folks.
And it is primary care. I mean, it is
primary care, yes. Yes.
Oh.
And so that would be a thing that if you providers have questions about how to incorporate that or what that might look like, you can reach out to Hi Sis. I will have all of the links under they'll be here with the podcast. But I would love to talk a little too about kind of how to help set realistic expectations for our patients if we're referring them. So, or even if we get lucky enough to have advocated successfully and get it incorporated into our office. So for electrolysis, if someone's going for electrolysis, let's say facial hair first, let's do that. Typical, average number of sessions and how far apart they're spaced and how long each session is, kind of expected course.
So there's no way for us to tell you how many sessions. It really just depends on hair type, the density of the hair, that kind of stuff. And if you were plucking or have had waxing, so anything that could damage the hair follicle could also prevent, removal, and so there's a lot of factors there. I typically tell people, because they're always going to ask, how long is this going to take? It's going to take as long as it takes. That's the end of the day. So 12 to 18 months is going to be the bare minimum at that point. Because, hair grows in cycles, and we just have to catch the cycle, specifically on the face, the anagen phase hair, which is the beginning hair where we need to treat to effectively kill off the hair. There's only a small percentage of hair in that stage on the face. And so those are the types of things. So I always tell people within the first 3 months, you should see a significant reduction in the hair removal. Some electrologists will tell you 50%. I don't say that because, again, that has to do with, how often you come, how long we're doing, that kind of stuff, how quick your electrologist is, that sort of thing. So when it comes to timing wise of how often you should do it, I recommend weekly. If there's somebody who has a full beard, let's do it weekly. Let's get as much as we can. How I usually do it is I work on one side and then clear that area up and then go to the next side so that that area has time to heal and do those types of things. So we're not doing too much damage to the skin because, we are shooting electricity and putting chemicals into the skin. So, we do have to have that kind of, kind of downtime, but you can, I mean, I've done 8-hour sessions. I've done 2-hour. Typically do just an hour with folks. But if somebody, for example, comes from one of our neighbor islands where they're only coming every so often, I will, do 2 or 3 hours with them, because it's pointless to come here for 1 hour. You just had to fly all the way here, take a day off, that kind of stuff. So, we can do as long as you want, especially if you have a medical director or someone that can do kind of injectable lidocaine with epi and stuff like that. So that way there's just less pain. One of the things that I would tell patients is this is not a painless procedure by any means of that word. I don't want people out there like freaking people out and telling them like, oh, it's so painful. It should be painful, but it should be manageable. It should never feel like your face is being burned off. And so that's an expectation that needs to be kind of set, because a lot of states are unlicensed. And so their electrologists don't have to have a license, and who knows where they went to school or what, they could have gone to the University of YouTube and just decided to do this. So it's just one of those things. And in no way am I telling other electrologists how to run their practice, but, it's just we have certain parameters about how we do what we do to preserve the skin integrity. And that's incredibly important, especially with donor tissue. If we're down there frying tissue, we may be causing infections, which could lead to all sorts of complications. Yeah. So, that's just kind of what the expectation would be. The person should be doing, if they're doing they're doing it for medical reasons, or what I call medically necessary. There should be photos, there should be documentation, there should be charting, those types of things. And so, at bare minimum, we should know when they came to the visit, what, settings you used, what probe size you used, and how long it was. We do a much more robust documentation, so because we just have an EMR, so that's just easier for us. But yeah, I mean, so just kind of setting those expectations, especially if you've never had electrology. And I would, encourage every person to go out. If you're going to send someone to do something, go try it. Yeah. And I'm not saying you have to go get go get a whole session. Just call a electrologist, say like, hey, I refer people, for trans care, and I know that you do it. Can I please come in and have, like a short 15-minute session or something, so I can feel what it feels like. And that's the best way, because I get people who are so scared that it's going to hurt so much that, when I start, they're like, oh, this doesn't even hurt at all. And I'm like, well, that's good. But, yeah. So it's just one of those things that like managing expectations for clients is different for obviously every client, but kind of letting them know that I always tell people this is a marathon, not a sprint. Like, yeah. This is you're here for the long game.
So minimum 12 to 18 months, weekly, hour-long sessions, average expectation, if accessibility works that way, for electrolysis for facial hair. And I think with most of the hair removal methods, there is some discomfort. And I usually tell people to do, depending on their pre-existing health conditions, either Tylenol or ibuprofen about an hour before a session, like half an hour to an hour before a session, and then like over-the-counter topical numbing, or I prescribe compounded topical numbing as well. And then yes, if you're working with a medical clinician, there's injectable blocks and things like that you can do to help with pain control as well. And then for laser, I know different lasers work differently, but like general expectations if someone was doing their face, like
sure,
treatment.
So you can only do laser once every 4 to 6 weeks. And that depends on the type of laser. And so you're looking at probably a good 4 to 5 sessions before you really, you'll start to see a significant reduction after the first and second session, but maybe 4 to 5 sessions, sometimes even 6 before you're seeing like full clearance, if that makes sense. But they're much quicker, and so like a laser session on the face probably takes about 10 minutes, and so, well, depending on the person. But most places will put on a topical numbing cream for that and stuff like that. So the appointment's usually about an hour, half hour to an hour. That is, so laser, YAG, Alexandrite, all of the kind of like gun lasers, they feel like someone is snapping you with a rubber band. That's the best way to describe it.
I'm just gonna say, I think it feels like someone's like slamming a nail into my jawbone, but
okay, I mean, everyone feels things differently.
Yeah, I feel like anytime it's like over a bony surface, I'm like,
yeah,
God, that hurt.
Electrolysis is the same way, and so the face is obviously one of the worst places to get electrolysis on, because over the bone, so over the jawline, the upper lip is absolutely insane.
All those nerves from your teeth. Mm-hmm.
Yeah. And so the one thing, kind of going back about topical numbing creams, it's interesting that you say that, because recently there was research that found that we actually have nerve endings inside of the follicle. And so there is kind of this new research coming out that like maybe the topicals aren't going to be helpful. So they're still going to feel things. Like that's the thing. You're still going to feel it. It's just going to be numb.
Yeah.
So it's, that's kind of an expectation, because people put that on and think they're not going to feel anything. That's absolutely not true.
No,
They also need to recognize that once that topical starts to dry, it's done. Like you're metabolizing it, and there are, obviously fast metabolizers, slow, so with my sessions, I always tell people, we can stop whenever you need to. You just have to say something.
Yeah.
So yeah, don't.
And if you do it at a medical facility, because where I've had some of mine done, I'm oftentimes doing it in combination with other things as well, and they will pre-treat me actually with like an oxycodone.
Yeah.
So I'll come, I have to bring a driver. Obviously I can't drive myself home after I've had a narcotic. And I've already gone through all of the consent process and procedure prior to being altered. But I'll come I think I have to be there 45 minutes early, and then they'll give me my little pill and my little water cup and leave me in my room. And for me, that was essential, because I actually, believe it or not, prior to that, had tried hair removal somewhere else that would not do that. And they were doing some other laser stuff for me too. And after 2 sessions, I never made it back. At every appointment I made, I would either no show or cancel, because I was so stressed out about how uncomfortable it was going to be. Yeah. And so, yeah, I feel like clinicians, I just want to be really clear. I think, and we've actually talked about this before, I think someone needs to go through the consent process unaltered. They need to understand what the procedure is going to be like unaltered. And then if they are going to pre-medicate with medications that are going to affect their cognition, they need to have a support person there to get them home. But yeah, I'm really comfortable with patients having stronger medication for hair removal sessions. Because as you just said, try it yourself. And I am fuck this noise.
Right. Yeah, no, and it's very real. The thing with pain and me, so there are some places that will actually put you completely under. So that to me is a little excessive in my mind, just because, anytime we're putting someone under anesthesia, big risk. But, again, that's not my place to tell anyone what to do. So, the biggest thing is do what you need to do to be comfortable. Because if you're jumping in my chair, you're going to make that needle move, and I'm going to burn you. We're going to have some other issues. You may push the needle into the skin, because we're not penetrating skin at all. There should be, no to minimal blood involved. Sometimes you accidentally poke someone. It's a thing. But yeah, so we're not penetrating the skin in any way. And so, there's just a real risk there. and I have some clients who will kick their legs and do all these things, and I just have to stop and be like, look, I can't continue. It's one of those things. So, we started selling kind of a higher dose of lidocaine cream just because, we're not physicians, so we can't. We do have a medical director, and we finally just got our malpractice insurance. So yay on that. So, now we can start doing the bigger things. But, previously we were just getting some tattoo cream. Some tattoo parlors have Russian tattoo creams that are maybe not so legal. But
patients can order things internationally. That's totally fine. Yeah. Clinicians, prescribers, I do a compounded BLT. It's benzocaine, lidocaine, tetracaine. Yeah. Talk to your compounding pharmacy that you work with the most often. They might already have like kind of a preparation that they use for that. Usually you can do like a 10, 10, 20. If you start putting more than 30 or 40% into a cream, it gets gritty. And so you kind of have to like 10, 10, 20 is the most. A lot of times 10, 10, 10. But those are kind of things to do. And when you do the combination, because they all have kind of different half-lives, there is a little bit like longer duration there. But yeah, I personally like really need the narcotic, and it doesn't necessarily make it hurt a whole lot less because it is kind of like nerve pain sometimes. It just makes me not care, right. Which lets me show up to the appointment, have the procedure done, and also exactly what you're saying, not move all over the table or like curse my provider or like fling an arm at them, not intentionally trying to hit them, but like kind of that stress response. And so, yeah, I completely agree. Anything you can experience as a clinician that you're going to recommend to patients, I love recommending providers do that. And I do think this is one of those things that like a pre-procedural benzo or a pre-procedural narcotic, you are not prescribing, you're not prescribing 90 every 90 days. Right. You're prescribing, 12 for a 3-month period because it's 1 a week. Right. And so like providers, this is like a very different thing. And also obviously talking to patients about the risk of dependency and all of these things. But, I think these are appropriate uses of these medications. I want to ask about were you calling it E-Lite?
Yes.
Okay. So what is kind of the expected, like how frequently can you do that one? Like duration, like what's the details on that one?
So E-Lite is just a combination of radio frequency and IPL. So it's just IPL with radio frequency. The concept is that, the IPL is acting in the way that IPL acts to do hair damage, and that the radio frequency follicle in addition to that. So that's the combination of the both help to kind of get rid of hair. What I've noticed is you don't see kind of a sometimes when you get laser, you get like patches of hair that is gone. I've noticed that this is more of a gradual lessening of hair, and the hair just kind of slowly stops growing. That's just kind of a personal experience of what I've seen on clients. And so that's the biggest thing. So E-Lite is just kind of like laser. So it's every 4 to 6 weeks, depending on what the practitioner. I would say 4, just because working with folks who are experiencing gender dysphoria, waiting 4 weeks is not easy. I have one client who every week will, can I come in this week? No, boo, you have to stop.
Come now.
I can do the electrolysis. So the one beauty is that with laser, you have to wait 6 weeks between that and electrolysis. So you can't do that. With the E-Lite, I found that I can do electrolysis because there's still viable hair. So that's the concept is that when you're going through and just kind of frying all the hair, the bulbs aren't there, and so it's just not effective in treatment. I've noticed that with E-Lite, you can. Or, you can treat one side of the face 1 week and do electrolysis on it, and then switch, in the 4 weeks or whatever. But yeah, so it's really up to the practitioner, and I think it's really specifically with folks who are dealing with that facial dysphoria, facial hair dysphoria, is finding what combination of these things works. You know, I started off kind of very anti-laser because, of course, it wasn't permanent. You know, you just kind of get in that way. And then I realized, like, if I can reduce the hair significantly, it's not going to matter whether it's coming back if we're still doing electrolysis, just because we're going to treat that hair anyway. But they're going to see a result, and they're going to be much happier. And so, you know, they're going to feel better about it. But I also just have people who feel better getting into the chair. And, you know, even if you clear one little spot on the face because they can't handle the pain, they will literally sit there and rub that spot. And I'm just like, quit touching your face.
We just did some trauma to the skin.
Right.
Please wash your hands.
But there's like, I don't know, there's this beauty in when you do that and they're looking in the mirror and just that euphoria. Like that's why you do it. You know, it's like, it's kind of amazing. If you've never seen anyone experience gender euphoria in a moment, and you're there in that moment, that's just, it's amazing.
So good. It's so good. And so this has been a lot of really useful information. I think one of the other things like referring clinicians should know is how to counsel their patients on how to prepare. Mm-hmm. And so like very specifically, I think about like, when should they stop waxing, plucking, epilating, right? And that kind of counseling. So what should they tell their patients?
So if you're still using an epilator, put it away. That's from the 90s. Stop it. Because all it's doing is tearing hair out. And so if you have a client, they should not be waxing. They should not be plucking, and they shouldn't be doing any kind of thing that's going to pull the hair out. Yeah. That's going to damage the follicle. It's going to make it harder for us. The one big thing is we tell people, do not pluck. Stop it now. Because you're just going to end up with those 90s eyebrows where the hair stops growing completely and it just damages the skin. And it also creates a lot of ingrowns. Those types of practices can create a lot of ingrowns, a lot of damage to the skin, especially if, you know, the waxer is not great at their job. They can burn the skin, and then we have an issue because we can't work on it. And so those types of things, we just tell people to stop doing. With waxing, I always tell people it should be 6 weeks, just because, again, the hair cycle. With plucking, we're fine. We can just start immediately and that kind of stuff. Every electrologist who is in care should be doing a consultation. You know, I don't care who says they don't or whatever. I just believe that's, you know, we're all taught it. It's taught in the schools. We should be doing it, because that's how we're going to answer the questions. You know, it should not fall primarily on the provider to answer these questions. We should be the ones answering the questions. All of these things are in my consultation. You know, you should stop doing laser. It's going to take 6 weeks. The only thing you should be doing is shaving. And I have to have enough hair that I can pull the hair out. So it has to have enough length. So, you know, for a lot of folks who grow hair very quickly, you know, that could be 3 days. So that's 3 days without shaving. Now, some electrologists tell people just to stop shaving altogether, which, you know, everyone does what they can do. I just know that a lot of my folks, there's no way they can do that.
Yeah, no.
You know, even with masks at this point, they're just not willing to do it.
Yeah.
Or they have jobs. You know, we're in a very heavy military place, so they have to be clean shaven. And so, you know, I've had to adjust my schedule to be open on like Sundays, for example, so that the military folks can stop shaving Friday night, you know, and have enough growth. And so that's just kind of what we would do. So we would kind of go there, but just kind of stop doing everything but shaving.
Yes.
If you do want to wax, it should be hard wax. So hard wax is often pulled with the hair, the grain of the hair.
Yeah.
Soft wax is pulled against it. Anytime we're pulling against the follicle, we can distort the follicle and damage all sorts of stuff. So, you know, most of it's about preserving the integrity of the follicle for us, just because that's where we do our work. But, you know, so it just depends. If we're going to do donor tissue, like specifically if we're doing kind of genital donor tissue, we need to make sure that that person does not do anything. They don't technically need to shave down there either unless they want to. Sometimes it's easier if they do, just because, you know, it can be very jungly in that area.
And to clarify for our listeners, this would also be true for phalloplasty donor sites. So forearm, thigh, abdomen, hair removal. Again, like you want to cause as little trauma as possible to that skin pre-harvest. And so not using any of the like potentially harmful hair removal methods. And yeah, I think my hair removal person told me like, no, nothing but shaving for 4 weeks before I showed up for my appointment. And so I totally agree with you. Like everyone should get a consult with their hair removal person and get to learn more from them, because us as referring providers are not going to know all of the intimate details. But I think being able to tell your patient, you're going to have to stop waxing, sugaring, threading, epilating, plucking for at least like, 4 weeks before you go to a session, like helps them like understand, because people get so excited, and so like if they come to you for their consult and then have to wait like another 6 weeks because they did some hair removal, that means you can't access what you need. And so I think that's a good bit of information to give our patients. And yeah, like especially for donor tissue, I think counseling around not doing any of those things that are going to damage the skin or damage the follicles, so that the hair removal can be more successful. Yeah.
And really I think it would be really great if referring folks could kind of explain the hair cycle a little bit, so that people can understand that this hair is going to regrow, like, or look like it's regrowing.
Will you tell us how you explain the hair cycle? So we have a little, because that was, med school was a long time ago, and I remember very little about it.
So I always tell people there's actually 4 stages, right? So there's a lot of people say there's 3, that's whatever. So the first stage is anagen. That's the growth phase. That's where because what we're trying to get to is the dermal papilla. So that little area at the bottom where it attaches and gives nutrients and that kind of stuff. So that's when the hair is still attached. And so that's when we can effectively treat it. Next stage is catagen, and that's when the hair starts to detach and starts to kind of die off, and it's ready to start moving into its final resting stage. That just sounded really weird, final resting stage. But sometimes if we catch it early catagen, we can effectively treat it. Telogen is the last stage. That means the hair is ready to come out. And the final stage is actually called exogen, but it's also when anagen restarts. And so that's where the discrepancy between 3 and 4 happens. Some people say there's 3 cycles because anagen restarts, but exogen is when the hair actually comes out. The beauty of shaving is if you have telogen hair, a lot of times you're just going to pull that hair out with the razor. So it's not going to cut it because it's not attached to anything, and it's just going to pull right out. And it's exfoliating as well. So that's how I describe it to folks. And I always tell people there's 2 types of regrowth. There's apparent regrowth and actual. So apparent regrowth is I've treated an area and you're starting to see hair grow again. Now remember, it's a cycle. Not every hair cycles the same time. Not even a group of hair may not cycle at the same time. And so just kind of going and saying that's apparent regrowth, that's stuff we haven't treated. There's actual regrowth, which is stuff that we have treated that's coming back for whatever reason. Either it was in early catagen or late catagen and we just didn't get it right, or for some reason we just didn't hit it in the right spot. And usually actual regrowth happens at that 3-month mark, that 4 to 6 week mark, when we have hair regrowth. And so, and I always tell people, my favorite thing I hear all the time is, I'm growing more hair. No, you're not. You're born with every hair follicle you're ever going to have. It's your hormones that are indicating when to grow hair, what kind of hair to grow, and so the different types of hair, like vellus versus terminal. And so especially with folks who are experiencing PCOS and hirsutism and things of that nature, I always try to explain to them, like, you may see more hair growth because you have an androgen like issue that is telling your hair to actually grow. So we normally only see female presenting folks with PCOS, but it's just that kind of thing. But yeah, I mean, at the end of the day, it really just depends on hormones. It depends on that kind of like where you are. Now when someone's on estrogen, it actually kind of makes the hair a little bit finer, especially over the body. And it can happen with the face. And so that happens and usually peaks around the 2-year mark. So that's also something to kind of be in consideration of, that as estrogen kind of like, as you build that, reserve, I don't know what to call it. It's not a reserve, but as estrogen kind of builds up in the body, you may actually start having different skin reactions as well. I've had people come in, everything's fine, and then they start estrogen, and now we're having, histamine reactions. And so those are things that, I describe in our consultation, and just kind of say, hey, these are the things that are possible of happening. So, it's very simple.
Have you seen, I feel like one of the things that I've kind of noticed, and this is just like a clinical observation, clinicians, this is not evidence or research based by any means, but it seems like estrogen can sometimes speed up the loss of pigment in hair for my patients as well. Have you noticed that, or I'm curious if anyone else has noticed that?
It's rare that I have anyone that's like just starting estrogen or any type of hormone. And so I don't know that I've seen that, but they verbalize that to me, like, oh, I'm getting way more white hair. And I'm like, well, you are getting older too. So, like that.
Yeah, but it seems to happen like really quickly with the initiation of estrogen. It's kind of interesting. I don't know. I would be interested. I could maybe try to come up with a theory behind it. But anyways, well, I want to respect your time. And you've been such a great guest. But is there anything else you would like referring clinicians to like know or talk to their patients about, like any more like hot potatoes for you?
Yeah. Okay. There's a couple of things. One, come and meet us. We're part of your team. At that point, you're referring someone to us. We're now part of your team. And so you need to know who we are. There are plenty of electrologists out there who aren't comfortable treating trans folks. I just did a study. We're finishing a study of that. And as a part of that study, I got a call from the president of an association telling me that I needed to stop sending out the survey because it was making people uncomfortable. And we were just asking whether or not they would treat trans people. So that's very real out there. So know who we are, know who you're sending people to, know whether or not they're good. Listen to your clients and patients when they come in and say, oh, you sent me to this person and it is not working. Trust me, it happens. So just know who we are. The second thing is that sometimes electrologists and estheticians and folks who are more like trade, quote unquote, people.
Not in the way we usually talk about trade on the show.
Oh, well, they could also be that too. We know that. That's what they do whenever. But, it's funny to me that we kind of get seen as uneducated, those types of things, and we kind of get put in these boxes when the reality of the situation is that most electrologists probably know more about hair and skin than you do as a primary care physician, because that's what we study, unless you're a dermatologist, and even then, like I've sent people back to dermatologists being like, I think you have folliculitis. You need to go see someone about that. So, we can be a line of defense for that kind of skin abnormalities and stuff like that. But also remember that medical school is just like, my mother always told me, medical school is like learning how to work on a car. They're the same thing. There's no real academia behind that concept. You know, we know what we know how it works, and now it's just about plugging the right things into the right places. And so that always kind of stuck with me, because that's how she taught me to be respectful of everyone, in the sense that, like, your mechanic knows way more about cars than, and physicians know way more about bodies than, you know. And so it's one of those things where, like, we're on a team. Yes, I understand you went to medical school and spent 900 years studying, and I have a great appreciation for that. Trust me, because I could never do it. And so it's just one of those things, though, that we would, on the flip side, if you could give us that same appreciation. You know, most of us did training for this. You know, it's only 600 hours, but you know, we do have to license, we do have to sit for exams. So, you know, and we are taught, there is very specific things we're taught. And, you know, so it's just, we're part of your team. Bring us to your, you know, bring us to the table and interact. Like, if I send you an email saying, like, hey, your patient is off the flipping wall, please understand that, like, something's not right there. And I'm coming to you as their primary care physician, as somebody who has their trust, because they may not trust me, to intervene on our behalf and say, hey, like, what's going on here? Because you may get answers that we don't. And that's when, like you said, they don't show up. And, you know, and unfortunately we lose money because of that. So
yeah. And I think, you know, I say the same thing about vetting your referral sources all of the time. Like, I think one of the absolute requirements for primary care providers is that you, at the bare minimum, are transparent about not having vetted someone you're referring someone to. So if you have not found safe referral sources for your trans patients or your patients with intersectional identities, that you're very transparent, that you're like, I'm referring you to someone I don't know anything about whether or not they're inclusive or affirming, like what their body, like any of that stuff. And so bare minimum requirement. I think the, you know, next step is absolutely what you're saying. You have vetted referral resources. And I know clinicians are really busy, so this is always a great project for a student. If you have like a pre-med student, if you have a pre-health student, if you have social work students, masters in public health students. It's also, you know, if you have like a gender care navigation team at your facility, this is something that they can be working on. Also, probably your local LGBTQ nonprofit has done some of this work and has a resource list on their website.
Some of them even have electrologists.
Yeah. And so, but yeah, absolutely, that should be required. And so for all of like people listed on our website, they have filled out like a form. So it's self-attested, right? And we're clear about that we haven't talked to everyone that this is self-attested, but there's definitely been people we have not put up on our website from the, like what they put in the self-attested form. And I do also, typically we look at everyone's website, and there's definitely been people who I've looked at their website and I've been like, and so I think that's essential. And I think it goes even further than just being trans inclusive providers. Because I think it's really, really important, like, to honor those intersectional identities. So like, don't refer someone with darker skin to a place with hair removal that can only work on light skin. You know, don't refer a patient with a bigger body to a surgeon who doesn't do surgery on bigger bodies. Like, those are really traumatic experiences, because again, these people we're so excited to get our care. Like, we have been waiting, you know, years for this, and like, you're finally getting to go to that appointment, and like, you know, it's finally happening, and then you get there and they're like, you're too black or you're too fat, and it's like, that's not great.
The size thing is really important, because know that your electrologist or esthetician or whoever you're sending them to actually has a chair that can support them.
Yep.
Like, my chair only goes up to 500 pounds, you know, so I have a secondary chair that is kind of like, it's broken, but it's a large exam table for people who weigh over 500 pounds. So if I ever need to use that, I have it. And so those are just the huge things. And currently I'm working with some colleagues on creating a gender affirming electrology program where we're going to actually train people, or, you know, and so that we can kind of like quote unquote certify people that have been trained, you know, so that we can say, we know that they've gone through this, you know, this thing, and they understand, you know, like putting your hands on someone's throat near the Adam's apple could be triggering, you know, so those types of things.
Yeah. So I think that's so important. Like, know who you're sending your patients to, exactly like you said. And then I think that intersectionality is so important in knowing where you're sending your patients as well. And, you know, it's like always like assigned to me, like, right, when I go to a facility's website and they have these things already on their website, right? Like, our exam table supports up to this weight. Our, you know, entry doors are this wide. Like, we have handicap accessible bathrooms, like, right, we have a gender neutral restroom. Like, if people are putting that stuff up on their website, it is a really good cue to me about where they are in their journey of like inclusivity and affirming practices. And so I think clinicians, that's important to remember. And I think, yes, like, doctors, don't be assholes, I think was the last point there. Every member of the care team has, like, you know, we're each a human. And so we all have exactly the same worth as humans and value as humans. And we all bring different assets to the table. And it's like, right, it is the joining of those assets that brings enough variety to the table to actually serve all of our patients, because our patients are various and broad. And we as individuals, like, don't get to be culturally competent in every culture. And so it's so, so important that we welcome each other kindly and respectfully, and that we really acknowledge each other's strengths and skills. As hopefully you felt when I was like, how do you describe a hair cycle? Because I don't know how to describe one.
Yeah, no, and that's just it. Like, you know, I say that because I've noticed that I get a lot more respect from folks because I have a master's in public health, and so they see that as someone who has, the only thing that says is that I've had time in the academy, and, you know, like, that doesn't make me any smarter or whatever. So it's just weird. So I see some folks being treated a little bit differently than I get treated, just because I have more of a baseline knowledge of how medicine works or how these things work. So, and I'm just really trying to make sure that everyone who's doing this work, especially those of us who are doing it in service to trans folks, like, one, that we're doing it the right way. And two, this is my community, and I don't want anyone to ever feel like what I've ever had to go through. You know, like, that's kind of the thing. You know, growing up, I grew up in the 90s. So, like, it was one of those things, you know, and I've been called everything but a child of God. And I just don't want people to ever experience that. And so, especially from someone you're supposed to be trusting. And, you know, if we can come together and be part of a wider team, that would be wonderful. And like I said, if anyone has any questions or needs any help, please just don't hesitate to call us.
Amazing. Thank you so much for your time today.
Yeah, thank you for having me.